Good, we're recording. I got it. All right. So what we're currently planning on doing is regional rating with 20 regions. It's a little hard to see the dynamics when you're looking at 20 different regions. So I'm going to start with a hypothetical scenario. This is just for illustrations, not actual data, but it does give you a sense for why we're moving to regional rating. So in this fictional scenario, we have 5 regions, A, B, C, D, and E. There's the same number of people in each region, but the cost per member varies across these regions. So in region E, the cost per member is $80. In region A, it's $100. Right now, what we do is we take the average across all of these regions and we just charge that to every single region. So as of today, region E would be charged a $90 statewide premium because that's the average across all 5 of these regions. So the cost per member is $80 in region E and the statewide average is $90 in this example. Region E could go out to the market, get a bid, and let's say their bid is a higher cost than what the actual costs in active care are. Let's say that the bid is $82. When we go out and we look in the market, we think we're pretty cost effective. Actually, we're very cost effective. We have a very large scale, so we have a lower admin cost ratio than what you might get. And because it's a large pool, there's just a lot of efficiencies there in terms of the prices that we can negotiate. So let's just say region E goes out and gets $82 bid. That's $2 higher than our costs. That's still lower than the $90 statewide average premium. And then there's a similar dynamic going on for region D. They're at $87, below $90. So you've already figured this out. Regions D and E, they're gonna leave. Almost all those school districts, if not all of them, are gonna decide, we're in a lower cost area, we can get rates outside of the program much cheaper, so we're gonna leave. Here's the big problem. D and E leave, and now we're left with regions A, B, and C. The average cost in those regions varies between $90 and $100. If you blend the costs in those 3 regions, you're left with a statewide premium of $95. Now region C can get a bid at $92. That's below the statewide average of $95. So now region C wants to leave. This could all happen in a very short period of time. We could go from statewide premium to announcing we're going to stay with a statewide premium. D and E decide, they tell us they're going to leave. We recalculate the premiums. This could all happen in 1 year or it could happen over multiple years. But long term, what we would expect to happen is that you would potentially be left with just 1 or 2 regions. And those would be the higher cost regions. So in this example, as an agency, TRS has done nothing, but the premium has gone up from $90 to $97.50. The benefit of setting rates on a regional basis is that every school district, every employer gets a rate that's competitive in that market. And so again, this is just illustrative. We'll get into more specifics later, but in this example, what we're doing is we're blending the costs across all of the different regions. So region E gets an $82 bid. That's competitive with what they would get out in the market. Region A gets $98 premium from TRS, and that's below the cost they would get outside of the market. And so every single region in this regional rating scenario would get a market competitive rate. To give you a little more details on what this could actually look like, what we did is we ran some scenarios to try to figure out what might actually happen. We don't have a crystal ball, so we can't predict the future with any kind of certainty. If we could, that'd be nice. But what we're doing here is we looked at school districts with more than 500 employees. What would happen if half of all the school districts with more than 500 employees decided to leave the program? And we randomly picked those 50% of the districts. So school districts with more than 500 employees, half of them with lower costs decide to leave. And we randomly picked the districts that decide to leave. And then we repeated that random selection 1,000 times. So we're coming up with 1,000 scenarios of lower cost school districts deciding to leave. And what we saw is that the most common outcome in this simulation is that there's a rate increase to every single school district that remains in the program of between 4 and 4.5%. There are some much less common scenarios where it's below 3%, but there's also some that are higher than 5%. And if you mess with the assumptions and you say most of the larger school districts that are lower cost decide to leave, you can get up to a 7% rate increase. And again, this would just be year one. So this issue would compound over time. Year one, 4.5%, maybe up to 7%. And then the districts that are now lower cost change and more districts decide to leave. And this would create a lot of uncertainty for your school district. Let me see. Did I confuse anybody?
We have some questions.
Yeah.
We did have one question in the chat. They asked, do we only have access to doctors and hospitals in our region? And Christina already messaged back with them that they'll still have access to the same plans and networks. Those will be the same for the statewide, only the rates will vary by region. Are there any questions in the audience?
We have will you read aloud that first comment that we got?
Certainly.
You need to address it.
Okay, in Region 15, we have already been given rates for 2022, 2023 via our optional program. If we have to give an all or none decision to TRS for a district by December 31st for 2022, 2023, we are having to make a major decision without all the facts from both regarding premiums. And we've had several other people agree with this comment.
Yeah, yeah, sure. I'll start and then Katrina can help me. Yeah, that's definitely something we recognize that is a difficulty for school districts. And I think at this point, there's just not much we can do about it because we can't set the rates until we know who wants to participate in the program.
And we only have 3 months of data.
And yeah, we only have 3 months of data. So the rates that you're talking about are starting September 1, 2022, going through August of 2023. And we have 3 months of data for the current plan year. And so we try to set those rates as early as we can. That's why we typically set rates in April to provide budget certainty before school district need to set their budgets in the summer. But that's definitely a constraint that we understand that school districts face. And that's why we're doing our best to provide as much data today to give you a sense for how your region compares to the statewide average to help inform that decision. I don't think that we can ameliorate all of the difficulty the school districts have in making that choice, but I would say that this is, for districts that are currently in the program, this is not a one-time thing. So if you're currently participating in active care and you're not sure, you can wait till next year. You're not locked in for 5 years. So you can see how your region compares today. And if you think you can get a better deal and you feel confident that based on how your region compares in the current rates, you can get a better deal, then you can go ahead and decide to leave the program. And then if you want to come back later, you can come in after 5 years. If you look and you say, hey, I'm not really sure, I'd like to see what the actual rates are, maybe get some more bids, you can wait till next year. There's no 5-year lock-in if you decide to stay in the program. So you can hang out, take a look at the rates. If you're not sure, wait and make another decision next December if you're currently in the program.
One other thing on that, sorry, this is Melanie Ingleby. I'm the healthcare actuary here at TRS. So one other thing to keep in mind about that is the flip side of this as well. We understand the difficulty with us not having the rates prior to this decision being necessary. But something that you should keep in mind as well is if you do decide to leave the program this year, you're making that decision for a 5-year period as well. So if you decide to leave the program today, you're making that for a 5-year decision, and you obviously don't have rates for years 2, 3, 4, or 5. So I would encourage you, as you're thinking about this, the rates today are obviously a consideration, but you also don't have a sight into those increases for subsequent years, even if we gave you rates for year 1. So, keep that in mind as you're making that decision to make the best decision for your district. No matter which way you go, if you choose to leave, you're making a blind decision for years 2 through 5, even if we gave you rates for year 1.
Well, and Melanie, can you talk about too, I mean, if a district decides to self-insure, I mean, there's no guarantee on the estimate from a consultant you get. At the end of the day, you pay those claims.
Correct. So if it is truly a self-insured quote that you're getting, it's really just a guess. So if what you're, I mean, there's a variety of products you could be looking at. So I'm not going to speak directly to which product you're looking at. I would be shocked if an insurance company is giving you a fully insured quote at this stage of the game, but maybe they are. You may be looking at a level funded product, which is a little bit different. But if you are looking at a self-funded quote from an insurer that they're offering you a quote today, that's basically an estimate of what your claims are going to be for the period. But at the end of the day on a self-insured product, you're responsible for the claims as they come in. So they can give you a premium equivalency rate. That's what you're going to pay monthly until your claims are in excess of that amount. And then you'll be on the hook for the claims that are over that amount. So it varies very much depending on what type of product you've been quoted. But a self-funded product, really a quote is an estimate of claims. And at the end of the day, you will be responsible for whatever the total amount of claims that comes in is. And they're just making their best guess at what it will be at this juncture.
Yeah, thanks, Melanie. And that's all just say, those are things to keep in mind. But at the end of the day, I mean, we do realize that it's a difficult decision in some cases for school districts. And so we are trying to provide as much data as fast as we can. And if there's other things that we can do specifically to help within the constraints that we have, let us know. We've got another question.
Kyle, we do have some more questions. I'm going to give you a couple at a time because they're kind of similar. They wanted to know, how do you anticipate 4% increase when the Sears rate increased around 8%? And along with the percentages, is a 4 to 5% increase on premiums on top of the 5% plus we typically see every year? And then there's more.
Sorry, I didn't quite get the 4 and 8. What's the 8?
Okay, it said, the first one is, how do you anticipate a 4% increase when this year's rates increased around 8%? So how are you seeing less of an increase is what I'm assuming that means.
Oh, I see. So there's 2 components to this, and let's hold some of the questions related to what we're expecting, but I'll give you a quick preview of that. There's 2 components. There's the adjustment of the regions. So there's a preview today of how we expect your region to compare to the statewide average. And that will be added to whatever we need for the statewide trend. So there's 2 components.
How about the statewide trend that we experienced for the current plan?
Thank you. Yeah, I was going to say that and I forgot. Thank you, Katrina. Yeah, so part of the issue for the current year is that we are experiencing adverse selection. And what I mean by that is there are a number of school districts that are offering another plan alongside of ours through a District of Innovation or DOI authorization. And the impact of that is that in most cases, the vast majority of districts, that coverage is attracting healthier employees and it's leaving active care with people who need to use more healthcare services. And just to give you one example, a lot of the plans exclude or largely exclude specialty drug coverage, and our plan does not. And so what happens is the people who don't need specialty drug coverage take that other offering outside of active care. And then the ones who do need specialty coverage stay inside of active care. And so when you have only the people who need healthcare services and you don't have the healthier lives, then you have to charge the people who remain in your program more money because you can't spread the risk among as many people and you don't have those healthier lives. And so there's a good portion of the rate increase that the board just last adopted is due to that adverse selection from Districts of Innovation. And the whole idea behind Senate Bill 1444 is that that type of adverse selection does not benefit the employees inside of active care. But the legislature recognized that school districts do want flexibility for their employees. And so to provide that flexibility while providing stability for the program and those school districts that want to remain, what Senate Bill 1444 does is it closes that loophole. So a school district can't offer additional coverage alongside of active care. But if that coverage is attractive to the school district, they can leave active care and decide to offer that to their employees. And so the rate increase for this last year, a good chunk of that is due to districts of innovation and that adverse selection.
So the current plan year that we are in, just to put some numbers to what Kyle just said. So for the current plan year, less than 4% of the premium that we charge is attributable to trend. Nearly 3% of the premium was attributable to this adverse selection dynamic that Kyle was describing. The fact that, and here's a let me make a point about active care. So there are not a lot of hidden costs. In fact, there are no hidden costs in active care. There are no commissions. There aren't big profits. Active care spends 96% of its money on healthcare claims. So medical claims and pharmacy claims. So healthcare cost, the cost of your employees and their dependents getting healthcare is what drives the overwhelming majority of cost in active care. Only 4% or less goes to administration. And when I say that, that's all in administration. What our team gets paid, what we pay the Blue Cross team, the administrative fees that we pay Blue Cross, what we pay CVS Caremark, what we pay our external actuarial consultants, and what we pay our healthcare consultants to help us stay on top of trends in the market so we can design the plans to best meet your needs and avoid unnecessary costs. So when we see the adverse selection that we experienced, and when I say we, it's active care, but it's you, because any change in healthcare cost in active care gets passed straight on to the employers that offer active care and then on to the employees. So if we see an increase in healthcare costs, which we did, because we had healthier employees and families migrating to those alternative plans that were offered alongside active care, and active care retained the higher risk employees, folks who were on specialty drugs or managing chronic conditions. When that happens, we saw among the employers that offered alternative coverage, among those employers, we saw a 25% increase in cost. Spread across the entire plan, it resulted in nearly 3% of the premium that we needed for this year just to make the plan whole. So that's how that dynamic worked. Now that goes away. This is the last year that that's permitted. If an employer, if a district wants to offer something besides active care, they have to make a choice. You have to make a choice. You either offer active care and you take all of your risk to active care, or you go to a different plan and you take all of your risk to the other plan.
Kyle, I have a few more. Do you want them now?
I've got a question. Right?
Yeah, go ahead.
Is all right?
Yeah, go for it.
All right. My name is Mark Parsons. I'm the superintendent by Itascasty. Here's my question, talking about the regional rates. About 4 or 5 years ago, we transitioned our benefit provider who used to work within Region 12, left and went to Region 11, and we stayed with that person because of the quality of work. So we provide TRS active care through a provider through Region 11. With this new regional rate system, will we be mandated to use the rates out of Region 12, or will we be able to follow him with him being in another education service region, if that question makes sense?
I think I understand your question. I know how to answer at least part of it. So for purposes of your rates, it's based on the education service center that you are receiving services from. So if you go like on the
Where you're geographically located.
no, there's
Yeah.
some instances where it's the region they're served and not where they're located. So for almost everybody, it's where you're located, but there's 30 school districts that receive services from an EST that they're not actually located in. And so for purposes of setting rates, it's where they are served in. I believe we plan, is this correct, Christine? We're going to post a list of which ESCs each, oh, it's up online now. Okay, so Christine's going to put it in the chat and you can double check which one you are listed on for purposes of setting rates. Does that answer your question?
Yeah, so we are restricted to the rates by what service center we get service from.
That's correct. But I
Even
don't,
if we're closer to another service center geographically.
that's correct. But how we set the rate shouldn't impact how you work with the staff through the ESC, because those are two separate things.
Okay. Yeah, I guess my question there lies, if we are geographically closer to more providers in a more urban area, is that going to affect us if our service center is on the other end of the region?
Do you want to tell me which district you're in, and I can message you privately to tell you where we have you assigned?
Yes, ma'am. I'm Itasca ISD. I would be sure that I'm assigned to Region 12.
Itasca? Okay, I will look at it and I'll message you.
Thank you, ma'am.
Thank you, Melanie.
So Kyle, this is,
What if you're kind of like him, where you're both in different regions? What if you change regional schools? Your rates go to whatever regional center that you go to, or how does that work?
Melanie, do you want to take that one? Did you, I'm not sure if you could hear the question, but basically what
If
happens?
not,
Okay, I'll repeat it.
Okay,
If I get it wrong, let me know. If they change who they receive services from their ESC, will that change how their rates are set?
potentially, yes. So, it depends on the TEA assignment is what we're using. So we're using the TEA assignment. So if that changes your TEA assignment, that would affect things, yes.
okay, thank you.
Okay. All right, keep putting your questions in the chat and we'll keep working through those as they come in. So one thing before I show you what we're currently seeing in the data is that this is not an estimate of 22-23 rates. Again, there's the statewide trend and then there's going to be the regional adjustment. So what we're going to show you is our current estimate of the regional adjustment, and that we expect that to be largely stable. We've looked in prior years and the numbers that we're going to show you today have been largely stable across years. That's why we're showing them to you, because we think that it is helpful information to inform your decisions. But these can change through April, because if school districts decide to leave the program or new ones decide to join, that will impact obviously the experience in your school district or in your region, and the enrollment can change obviously as well. And we'll talk a little bit more about that, but that's just something to keep in mind. And quick recap from the video, just before we look at the map of the rates, is that what we're doing is we're taking the average rate for the whole state, and then we're going to adjust them for your specific region. And we do that adjustment by looking at the historical experience. So we look at the claims data that we have paid for all of the people in your region. And then we tried to forecast the cost going forward. And we use a mix of age, gender, and risk to help make that forecast. And what I mean by risk is we're looking at the health conditions that impact spending on a going forward basis. End of the day though, what this really is are the claims in your region, do they cost more or less than the statewide average? And that's what we're trying to figure out. And that's how we adjust the regional costs.
Hey, Kyle, real fast, we have a
Yeah.
couple comments that I'd like for you to address.
Yeah, thanks.
Is there a way to combine TRS and ERS insurance to keep the pool large enough to be competitive? And then someone said, I agree with that comment. Why is ERS so much better than TRS?
So I'm going to try to answer this partly, but I can't answer it all the way. So the structure of ERS and TRS is something that's set by the legislature. So we cannot do that at TRS. That's a legislative decision. The reason why benefits between ERS and TRS are so different That largely has to do with the amount of funding that's available to reduce the employees' portion of those costs. If you want to send an email to us, I can actually send you a link to a report. We work pretty closely as part of a 5-agency collaboration to look at healthcare costs. And if you look at the cost per employee and you look at it in detail, even by ages, the costs between ERS and TRS are not that different. So the big difference has to do with how those programs are funded.
Okay, and one other question or comment. The admin costs are a bit irrelevant when the reason folks left TRS because of DOI options was because the premiums were higher, co-pays were higher, and the PCP requirement was infuriating. Somebody else said we will, someone asked about the PCP as well. Will we continually have to get referrals through a PCP? That is costly and time off work and financially to continually get these referrals for everything.
So I think as of right now, we don't have any plans to make major changes to the benefits for the upcoming plan year. Having looked at the data, I can tell you that in general, employee satisfaction with the primary and primary plus plans are among the highest in active care. I have heard in prior sessions that there are some frustrations with the specialist referral, but in general, people are much more satisfied with those two plans. So it's something that we continue to evaluate on an ongoing basis. Actually, that's my team is taking a look at that right now. We only have 1 year of data, so it's something that we have to continue to track and evaluate. And as the information comes in and we learn what the impact of that is, that will inform future decision making. So it's not something that we just put in place and then forget about it. And I do understand that sometimes there can be frustrations with that. But as of right now, there's no plans to change that. But as we receive more data, we will continue to evaluate that.
Okay, and then there's one more question, and a couple of people are still having the similar question, but in Sealy ISD, we are in ESC2. Most of our staff use doctors and hospitals in the Houston metro area. How will our region affiliation, which is more central Texas, affect our access to Houston area medical care?
Short answer is there's no impact. So it is a little confusing because there's a map and we're splitting up the state. That's for rates only. There's no changes to the network. So if your employees are accessing care outside of the region, that's already included in the process for setting rates, because those rates are set based on the cost for your employees in your region. And that includes where they're accessing care today. And so there's no changes to the network. There's no impact from regional rating to access to care. Can you wait just 1 second so I can give you a microphone? Sorry, there's a lot of people who want to hear your question.
We have roughly 50% of our employees who have insurance use Conway Health Plan rather than the
Mhm.
Do we know how that might be affected? I know most people.
Yeah, so if you're talking about the fully insured Scott and White regional HMO product, there's no changes as a result to what we're talking about today, because that plan is already, the rates are already set specifically for that region. And that's something that's an industry standard practice. And that's why we're moving in that direction for our self-insured plans, which would be primary, primary plus, and HD.
So no benefit or detriment either way.
To the
If you're
Scott
in a-
and White
if-
plans,
if-
correct.
Yes, so if you wind up that if you're in a lower cost region, you may still see the same rates that you've seen in the past. Higher priced region could still, they pretty much stay the same.
Yeah, so the way it works for the fully insured regional HMO products is that the carriers actually come up with the estimates for the rates for those products. They submit them to TRS and we review them to make sure that they look reasonable. But other than that, it's up to the carrier to set the premiums for those plans. Yeah, what everyone's interested in. All right, so here's the slide I think most people came here for. So I've said this a couple times, but just to be clear, this is not your rate change for the upcoming plan year. This is how we expect your region to compare to the statewide average based on current data. We expect this to be stable, but it can change up through April when the TRS Board of Trustees sets rates. Biggest reason it would change is because of participation, but also we're going to receive more data as the plan year goes on. And if you are in, let's say, ESC Region 12 Waco, -8%, that means that we expect that the rates in that region will be 8% below the statewide average. If you are in ESC Region 6 Huntsville, 0%, that just means we expect that the rates there will be the same as the statewide average. And Austin, ESC Region 13, it's 9% below. So we'll essentially take this number, add it to the statewide trend that we need, and that would be the rate change for your school district. So if you are in ESC Region 13 Austin, and let's say, I don't know this number, but let's just say it's 5%. We need a 5% statewide trend increase, but you're 9% below the average. That means you would be getting a 4% rate decrease on average. It's going to look a little different depending on the plan and the tier, but that's just the average across the plans. Does that make sense? Melanie, did I say something about what you actually do? That's
I think you're
incorrect?
good.
Okay. Melanie's the one that sets the rates, so I just want to make sure I got that right.
Melanie, along with help from our Siegel actuary consulting firm. So not Melanie in a vacuum, but yes.
All right. Any questions so far?
I think, yeah, we have some questions we haven't addressed.
Let's get you another one real quick.
Here, is it on now?
Yeah, I can hear you.
So we have the Memorial Hermann question. Will providers from Memorial Hermann no longer be in network with TRS Blue Cross Blue Shield since they are splitting? Memorial Hermann is our closest hospital.
So I'm gonna take a stab at that, but Katrina had a really good answer for this recently. But my understanding is that that contract negotiation is still underway. It's unfortunately a friction that occurs occasionally in provider negotiations. And what BCBS is doing is trying to make sure that they can get the best rate so that healthcare remains as affordable as possible for your employees. And we will do the best that we can to keep them in the network at an affordable rate.
Okay, and then somebody else asked if a district leaves TRS, will they continue to receive their $75 state contribution?
So I think the answer is yes, but that really is outside of our purview at TRS. That's really school finance. And the money that you receive goes to your school district. And that $75 was set in statute when Active Care was first created. I'm not personally aware of that $75 being like earmarked in either the General Appropriations Act or the higher education or the public education funding formulas. So I don't think that the amount of money that your school district is going to change based on their participation status, but we're not ultimately the public education finance experts. So I would defer maybe to your CFO or whoever you work with normally on those types of issues.
Okay, and then someone else asked, does the rate process apply to the retiree insurance plan also? And Christina let them know that no, it does not apply to the TRS Care, which is a different fund and rules than Active Care. And then will all districts see a 5% increase regardless of the region and then an additional increase if necessary?
Yeah, let me pull up. So here's an example. So on the table here, the first column is the trend needed. So that's the statewide change that we need. So that bottom one's 5%. If you're in a region that's 2% above average on that map that we just looked at, then the rate change for you would be 7%. If we need a 5% trend and you're in a region that is 5% below the statewide average, then there would be no change on average. I know this is a really important question, so if you're still confused, please just keep asking questions, but hopefully that explains it. Go.
5% that you referenced is hypothetical. We don't know it yet.
Yeah, thanks. 5%, we don't know. So if you look in prior years and you look in the industry, 3 to 5% is pretty common, but we don't actually know what that is. Like legitimately, we have no idea what it is because we don't have enough data to make a decision or to understand what the current trends are. You can look into the past rate changes in active care, and it's often between 2 and 4%. That's pretty common, but we won't know until we receive more data. And so that will be determined at the April board meeting when the trustees adopt the rates.
Okay, and I know we've already said you aren't anticipating making any new plan change this coming year. But the question still remains, does TRS anticipate that the PCP authorization, i.e. for specialists, continue to be in effect going forward? So what about beyond this next plan year?
So we put the PCP, primary care doctor-driven plans in place a couple of years ago in response to some comments that we got from districts. So we, we're going around the state, we were meeting with school districts, and we were asking them what we could do to make active care better, more appealing. And one of the comments that we heard repeatedly was a lot of our employees gravitate to the high deductible plan because the premium is at the lowest price point. But then, that's some of our lower income workers, such as bus drivers or custodial workers. I think about, like, my mother was a cafeteria worker. So those employees are buying the high deductible plan because of the premium price point. But then when they go to access care, they still have the hurdle of meeting the deductible before they can actually access care. And they didn't like that. So we went back to the drawing board. We worked with our actuaries, and that's where we designed the primary care driven plans. So primary, active care primary and primary plus. And the primary plan, we were able to set at a premium price point below the cost of the high deductible plan and still have copays in there. So you can see the doctor or get prescription drugs without having to meet the full deductible. And so it was designed for that purpose. The issue that we have in healthcare is, look, healthcare cost is going up. I think Kyle was pretty conservative when he said that in the market, you may see a 3 or 4% increase every year. That's not what we see in medical CPI. It's actually higher. And so we in active care have been pretty successful. And I think we have a graph coming up to show you how we've beat the market every year. There it is. So what we try to do is, as Kyle was mentioning earlier, is we try to come in with premium increases and trend increases as low as possible. And it's typically been between 2 and 4% on average across all the plans. So the issue, like I said, 96% of our funds in active care, which by the way, all come from the school districts. We don't receive state funding from anywhere else. We did get some COVID funds this year, which we'll talk about in a little bit, but that was a one-time deal. We've never had that happen before, and I suspect won't happen again. It was federal funds were made available, and it really just plugs the hole of costs that we had related to COVID. But at any rate, so all of the money that we get comes from you, from the state contribution that's in the formula financing formula, the contribution that the employer decides to make alongside the state contribution, and then you payroll deduct the employee premium and send that to us. And that's all the money that we have to manage active care. And 96% of that goes to claims. Well, when that's the case, you have to figure out how can we lower the cost of claims. So healthcare is complex in some ways and simple in others. It's the cost per unit and the number of units consumed. So we try to get you the best deal on the cost per unit. That's a procurement that we did with Blue Cross. We got, Blue Cross offered a deal that was lower cost across all the regions of the state. Then you get into number of units consumed. And so one of the ways that you can affect that is you have a high deductible so that the member is deciding, do I really need this care? Do I really need to go to the emergency room, or can I go to urgent care? If the consumer is paying out of their pocket, they may think about that a little more. The other way that we can do it is we take sort of responsibility for that. And we do that through primary care directed plans, where we have a network that is broad, but has only the highest quality, highest value providers in it. There's not an out-of-network benefit. And we ask you to see a PCP so the PCP can help direct your care. So it's, we have trade-offs in how we can manage the cost of healthcare. And the PCP model is one of the ways that we can lower costs. But we've done some things to enhance those benefits for the educator population, because we know that you have special needs. One of them is we recognize the seasonality of work in the education system. So we've worked with Blue Cross to find a way to have better access to care outside of the Texas network if somebody's traveling. And we've also worked we know that some of you have kids in college that are still on your plan, but in another state. And so you can still be in the PCP driven plan that has a statewide network and get those kinds of needs met. So that was a very long answer to say they're probably here to stay, but that's one of the ways that we can help manage the cost and get the premiums lower.
Thank you, Katrina. And a response to that, someone said our district has teachers that take the high deductible plan because of the lower monthly cost.
And if they look and shop a little more, I think they'll see that primary from a premium perspective is lower cost and it has lower out-of-pocket cost.
And like I said before, we do a random sample to survey employee satisfaction across a variety of things at TRS. And one of the things that the agency looked at recently was how satisfied employees are by plan. And primary and primary plus, there's a noticeable difference in that people are more satisfied with those two plans than HD. And I think that that's for a number of reasons, including many that Katrina already mentioned.
Thank you. And just two more things. Oh, I just lost one. Sorry, my apologies. Okay, if our district decides to go away from TRS and is locked out for the 5 years, how will that affect an employee who retires the next year and wants to utilize the TRS retirees health insurance?
No impact.
Okay. And then one is about your slide, so I'm going to skip that one and go right back to it. But the one says just a little levity. Can we please add, please add massage therapy to the plans? After all of this, I am going to need a lot of it. Joking. And someone agrees with him. And then to your slide, it says the Texas self-insured employers percentage reflected. Who does this include? It was a previous slide with some, that one.
Okay. Yeah, let me come back to that in just a second. So the regional adjustments are intended to be basically a one-time right sizing of the program. So things can change over time, but we expect that what you see on this map, that will largely be done it will be done all for next plan year. And there won't need to be that kind of regional adjustment of this size in future years. And the benefit of doing that is that will help maintain the size of the program to continue to provide the types of benefit that the program provides now. And one example of that is that if you are out on your own as an individual school district and you're self-insured, the type of volatility that you may see is much, much greater than what you see inside of the program. So what we're showing you here is a random sample of 68 school districts. They're randomly selected. They're all different sizes, small, large, medium. And this is the medical costs per calendar year, per employee. And each one of these yellow, orange-ish lines is an individual school district. So it's cycling through all 68 school districts. And what I think you've noticed already is that there's a lot of school districts where it starts out maybe close to the statewide average and it goes up to 15,000, it goes back down, goes up again. And what that actually means is that if you are going to go out and try to do this on your own outside of the program, you need to find a way to mitigate that volatility. There's two ways to do that. You can buy stop loss insurance, which costs about 30% above the actual cost of paying the claims. So that's 30% profit essentially and margin that you don't have inside the program. Or you can put aside a large claims reserve so that if you have a good year, that's fine. And then when you have a bad year, you pay out of the claims reserve. But that money goes into that reserve account and then your school district can't use that money for anything else. It's essentially locked up. And so one of the benefits of active care that will continue is that because of its size, there's just a lot more stability. So yes, the rates do go up and healthcare becomes more expensive. Unfortunately, that's something that we cannot eliminate as an agency. And we understand that that creates affordability issues for employees. But if you compare the rates relative to the benefits inside of active care on your own, we expect that you'll find something very similar to what we find when we go out and look at the market. And that is that the total cost of coverage in active care is very competitive relative to the market. So to answer that question, what's in the Texas self-insured employers is other large employers that self-insure inside Texas. So these are, a lot of them would be large companies, for example. And what you see is that the cost per member has grown 24% between fiscal year 13 and fiscal year 20. And that's the cost, that it says allowed charges. And what that means is that's the cost that the plan pays and that's the cost that the employee pays added together.
We have someone asking about Memorial Hermann again. So do districts served by Memorial Hermann currently need to assume that there will be no resolution to the dispute with Blue Cross and Blue Shield Texas? It will be hard to tell our staff we're going with a plan that currently and potentially all of next year not provide you with access to your current doctors or nearest major hospital.
Okay, I tried before, so I don't think I adequately answered this question. So can someone else help me? Because I understand this is really important to this district that's asking.
So currently, Memorial Hermann is in network. They have a contract, an active contract, and the contract doesn't expire until March of next year. So there's plenty of time for the negotiations to play out. And I'm confident that they will. If you think about, so Blue Cross Blue Shield has the TRS contract, as you know. They have the Employees Retirement System, so the state employees system contract. They have University of Texas contract, of which there are a number of employees who live in the Houston area. They have, and they have other large employers as well. They have a significant share of the Texas market, and it would be difficult, I think, for Memorial Hermann to say, we're not going to take the contract and we're not going to get the steerage from Blue Cross Blue Shield. So right now they're, negotiating. Memorial Hermann obviously wanted a higher rate. Blue Cross is trying to, as Kyle said, keep the rate down and keep it more affordable because again, I keep talking about how, what a significant portion of your premiums are attributable directly to the cost of healthcare itself, the claims. And so when a significant system like Memorial Hermann asks for a big increase, I mean, you're going to feel it in the premiums. So they just need to, Memorial Hermann and Blue Cross need to work through their dispute. And I'm confident that they will. These sort of provider carrier breakdowns happen all the time. It's a very common occurrence. Before I came here, I spent a decade as a regulator at the Texas Department of Insurance. We saw these all the time, and they overwhelmingly all get worked out, sometimes in the 11th hour. I'm going to say often in the 11th hour, unfortunately, but I think they'll come to a resolution. I also want to address another comment that I saw in the chat about the PCP plans. We do have a plan offering that is on a PPO platform. No referrals are required. And that's our high deductible plan. So if somebody doesn't like the primary care driven plans, they can certainly select the PPO plan, the high deductible plan that's still available.
Katrina, you might want this one. Would TRS be willing to send a representative to our district or region to present more info and answer questions? I trust you're feeling our pain as superintendent.
Yes.
So would you like
Yes,
them
we,
to contact their
uh,
district ambassador or contact TRS? or-
However you like, we're here for you. Yes, I'm happy to come to your district. I'll go to as many as want us, and I can physically work in. We've got a team. We can share some of that as well. Yeah, I'm happy to come into, I know this is a difficult decision. I can't fully say I share your pain because, I don't walk in your shoes, but I know these are difficult times and this is a difficult decision. So we want to be here to help you. And as you ask for your data from us, I'm sure many of you have, and if you haven't, you might consider that. If you shop and look for quotes, we'll be happy to help you with that too. We will give you objective information. We don't earn commissions, as I mentioned earlier. So while we hope you all stay, while we hope that we can make active care the obvious plan of choice for public education, this is what we do all day. We care about you all and your employees. We want to make this a better plan for you, but we don't earn a commission if you stay. So we don't have a financial interest in keeping you in the plan. So we'll try to provide you objective information. If you have questions, we don't want to give you advice necessarily, but we can help you maybe sort through some of it.
Thank you, Katrina. There is another question. Isn't it likely that, as you stated, the most healthy districts will opt out and those that are left, less healthy, should expect larger than average annual increases in premiums as the overall remaining districts will no longer benefit from the healthy districts being in TRS Active Care? This should therefore result in even more districts opting out a year from now for 23-24, which should raise the rates even more.
Yeah, I think that's a good question. The answer is the entire reason why we're moving to regional rating is to ensure that we remain competitive in the market. And so our expectation, having looked at this data, is that these regional adjustments will provide a highly competitive rate for school districts that are in the program that would be better than, in most cases, what you can get outside of the program. So we've looked at what school districts outside of active care, how much it costs to provide care in those school districts. We've looked at, I think it was like about 40 school districts covering over 80% of the employees in Texas that are outside of active care. And for the vast, vast majority of plans, our plans come in at a lower total cost than what you see in those school districts. And the reason why that's confusing sometimes is because people take one portion of the benefits and compare them without looking at the whole thing. So when you're shopping for healthcare for an entire school district, you have to look at how much the school district is putting in, how much the employees are paying, and then what the employee cost sharing is. And so sometimes people look at just the employee portion of that premium and they say, hey, the employees are paying less for coverage, so they must be getting a better deal. In almost every case, what's going on is that the school district is putting in more money to reduce the employee share of the premium. And so that's why it may look in some cases like this coverage in another school district is better than what you can get in active care. The reality is, if you add up actually where all the money is coming from, the employee, the school district, and then your out-of-pocket costs, active care is very competitive. And having looked at the market, we expect after these regional adjustments that active care will remain very competitive. And we know that there's some school boards that are making decisions in the next few weeks. But as of today, it's fewer than 30 school districts have provided a notice to us intending that they plan to leave the program. And we have a few school districts that are deciding to join for the first time. And when we look at these rates that you're seeing, or these regional adjustments on the map here, they're in line with what we see in other programs. So if you look on the individual exchange, for example, through the Affordable Care Act, if you go on healthcare.gov and you need to sign up as an individual, these relative costs are in line with what you see there too. And we've worked with Blue Cross Blue Shield to make sure this makes sense relative to the group market that school districts might get outside of active care as well. And again, it's in line with what you see in the market. So we obviously can't predict the future. There is some uncertainty. To say there is none would be ridiculous, but I think that based on all the information that we have now, we expect the program to provide a strong value and to remain highly competitive.
Thank you. And just one more comment. It says regional meetings with regional information would be very beneficial. And Christina replied to somebody else. She put in there that you can contact them at healthcarecomms@trs.texas.gov to set something up. So it sounds like they're appreciating these meetings.
Great. Okay, so I think I'm pretty much done. So just to recap, moving to regional rating will help us provide stability to the program. If we don't move to regional rating, rates would likely go up because of that adverse selection. The whole idea behind doing this is to provide competitive rates in each region consistent with what is out in the market. And we expect that active care, because of its size, will continue to provide a very strong value. So the premiums that are charged by active care, that's the only thing that the district has to pay. So there's no process to come back and collect that money if we're short at the end of the year. There's the risk to your individual school district is very low inside of active care because we set the premiums in April. The TRS Board of Trustees sets them in April, and those are the rates. And that's what is charged to the school district. There's very low admin costs that are difficult to get out in the market. And while healthcare costs do go up, and that does create challenges for school districts, we understand that for sure. Because of the size of the program, there's stability in rates across years that you wouldn't see as an individual school district being self-insured, and you may not see in other products. All right. Any other questions I can help answer? If not, I will pass the mic. All right, thank you.
All right, thank you, Kyle. So we're going to go ahead and move on to future considerations for active care. I'll give it to Katrina.
Thank you. I just want to take a minute to make a couple of comments that we, so about 3 years ago, we undertook this effort to re-engineer active care. We were meeting with school districts across the state. We heard from you about the cost. We do have some limitations on what we can do to lower costs. I mean, the cost of healthcare is something you read about in the paper all the time. So it's a pain point that all employers and families feel. But we're doing things to try to make active care more affordable and increase the value to you as employers who are trying to create a total compensation package to attract new talent, and for the employees and families that work for you. So we'll be, this year, regional rating is the big movement that we are taking in active care. And in the not too distant future, we'll be looking at maybe making some tweaks to the underlying networks and maybe offering some network alternatives where that I think the comment that we most commonly get from employers is, what about my lowest cost employees? The ones who, that mentioned earlier, the custodial staff, the bus drivers, the cafeteria workers. So how are they to afford the cost of these plans? And so there are some things that we can do. Maybe we can have a more regionally focused network behind our primary and primary plus plans as another offering that could be at a lower price point. So we're working on pricing that out with Blue Cross now, and we'll look at other ways to innovate as well. We want to make sure that active care is meeting your needs. There's a continuum of sort of complexity of care, all the way from you can have telemedicine for your easiest visits. I use it myself and love it because you don't have to go anywhere and take time out of your day. But we recognize that that's as an employer, you're wanting to make that available to all of your employees, not just those who participate in active care. So we're looking at some ways to maybe configure a product where we leverage our size and use that to get you a better deal. We, sort of the next level up the continuum would be urgent care, or PCPs, or emergency care and freestanding emergency rooms, which we should all be avoiding. So, so we want to try to customize products. We hear from districts about some are considering and I've already placed on-site clinics in some of their facilities. I kind of think for a school district, when you think about the way the campuses are geographically arrayed across an area, maybe near site clinic solutions would be convenient without the hassle of administering an on-site clinic. So we're talking to some vendors about the possibility of having a contract where we would have some near site availability across the state. So those are things that I think we'll try to roll out in the future, and we'll talk certainly more about them as time goes by. But those are some things that we have in mind now, and we'd like to hear from you if there are other thoughts that you have. Unless we have questions on that point, we do.
Okay, there was one that says, I know the rates are in line with what's in the market. However, the benefits need to be a lot better for employees, specifically the deductible. And with the medical, it came back. So the HD plan being combined, the prescription and the medical deductibles.
So it's the challenge that we have is, again, it's the cost of healthcare that drives the premiums. So we, in designing that, we can design richer benefits, but that will drive up the premiums. So we try to balance the premiums with the array of benefits and out-of-pocket costs. So the high deductible plan, hopefully most people who are in that, if not all, are pairing it with a health savings account where they can put some pre-tax funds in and avail themselves of the tax benefits of that particular product. We try to keep that in line. We don't try to, we do, we keep it in line with the IRS requirements so that it's tax qualifying. If we enrich benefits though, we have to increase the premiums, and particularly around a high deductible plan, because of the IRS requirements, we do have some restrictions that we have to maintain. Otherwise, it doesn't, you aren't able to take those tax benefits.
Thank you. And then we've had two more questions come in about that figure, about how many districts have already decided to leave. One asked how many have already left, which we know no one has yet, but they want to know the number of districts who have decided to leave TRS Active Care as of today.
So as of today, we only have a handful who have formally told us that they intend to leave. I would say it's maybe 3 at this point, but we've surveyed all of you, and I hope all of you have completed the survey. If you haven't, we're probably going to call you and ask you what you plan to do, because we want to try to figure out how we want to have the best information possible for setting the rates. So right now, as Kyle was mentioning, we had about 2% who indicated that they might be interested in shopping outside of TRS, but they haven't formally notified us.
Thank you, Katrina. So thank you all so much so far for your engagement this morning. Hold on with just a little bit longer. I just have a couple more slides to go through. I'm going to talk a little bit about the impact on COVID-19 and then go through some reminders with y'all, okay? So first, let's start off with the impact of COVID-19 on the TRS healthcare plans. So like other health plans and organizations, TRS was also impacted by COVID-19. As of August of 2021, we had about 31% of our entire membership that was had a confirmed or suspected case of COVID-19. So that equated to about 200,000 members across the plans that had some sort of office visit related to COVID-19, such as a testing or diagnosis behind that. So that equated to about $286 million of healthcare expenses related to COVID-19. And that was as of August of 2021. In August 2021 of this year alone, we had over 3,300 confirmed COVID cases. Along with the COVID, as y'all all know, we did put some cost sharing in place related to telemedicine, testing, and inpatient treatment. So as I mentioned, we had $286 million total in COVID-19 related expenses. And I'm sure as all of y'all are very well aware, there were several special legislative sessions this year. This third one that just concluded here, TRS actually reported all of these expenses to the legislator, and in turn, we were appropriated those $286 million back to the program. So that is actually going to be passed on directly back to the healthcare programs. So that will help offset the costs in TRS Active Care, which is going to equate to approximately 5% in those premiums. So when we talk about that, that goes along with what Kyle was mentioning throughout his entire presentation. It's one of the benefits in being in such a large program such as TRS Active Care. We're in that position to put those cost sharings in and make those cases for appropriations, and it provides more assurance and stability for the employers. And I will also mention that this is the first time in Active Care's history that we did receive those additional appropriations for the healthcare plan. So shifting gears now, we're going to talk a little bit about the timeline for joining and leaving TRS Active Care. So as a reminder, if you have not done so, please take that intent survey. That deadline of December 31st is quickly approaching here. So as a reminder on here, if you plan to leave TRS Active Care, one, we need to know about it. That intent survey is not the last step in that process. There's actually additional information that you will need to send to us. If you leave, remember you are out for 5 years. I did see some questions in the chat regarding this, and Christina was chiming back in. If you leave also, so it's 5 years, and it also takes effect September 1st of the following plan year, and you are out for the entire 5 years on that. Some other key reminders on here, that if you're in a district that's currently offering other coverage and you don't notify us that you are planning to leave, and you have this plan in effect as of 9/1/2022, that essentially means to us that you are leaving the plan. If you fall in that bucket, we have sent a letter to your school district. It was addressed to the superintendent. If you fall in that bucket and you don't know what we're talking about with that letter, because we have had some individuals come up to us and chat with us directly about it, please let us know. If you're in the audience, just catch one of us, or you can also post it in the chat. And we actually have a slide with an email address. And I think Christina has also posted it in the chat where you can reach out to us regarding that. Some other reminders here. This is just additional guidance for employers. Christina has been really good throughout this entire presentation. She has been posting several links in the chat, but we really encourage you to bookmark this link. And I can't actually point to it on here, but it's the one down at the bottom. You see the hyperlink of trs.texas.gov/healthcare-your-way. So we provide up-to-date information on there as soon as we get it, some self-funding information on there, fact sheets, so forth on there. So please bookmark that and continue to look at that website for the most up-to-date information from us. So in conclusion, we've talked about your regional price plans here. We really appreciate everyone's attendance, joining us, the questions and so forth. So these regionally priced plans will reflect the cost in your area and population. They give you a regionally competitive rate, all while still giving you the purchase power of Active Care's large pool here.